Hi folks, this is Dr. Rob Cyrus. I am the Carb Addiction Doc, and today's video is going to be a preamble to about a three-part series video that I'm going to be releasing sequentially. I had the amazing privilege of talking with a young author, and in fact it was a beautiful throwback. The woman's name is Isabella Cooper, and she is a Ph.D. student working in the UK. And it was just this most beautiful throwback to when I was a PhD student in Toronto. So I'm kind of the old guy, she's the young buck, and just quite amazing. So what happened is that Isabella and a group of people that I deeply, deeply respect on both sides of the Atlantic wrote a paper. And the paper has an interesting title. It says, Ketosis Suppression and Aging, the effects of suppressing ketosis in long-term keto-adapted non-athletic females. So I will explain that. So this first video is to explain the paper, go through some of the basic premises of the paper as a preamble to the interview I did with Isabella. And so what does the paper do? So this paper, and if you look in the show notes, the title of the paper is going to be there, so you can link to it. What Isabella did, she works in aging, she works in the metabolic space, and what she did is she set out a study to look at what the health parameters for a ketogenic diet are. And I can tell you that this paper, for anybody that's a biohacker out there, this is biblical in terms of the blood work that it represents. But the beauty is, in order to get this through IRBs and institutional review boards to make the paper ethical, she turned the hypothesis on its head. And what she did is she took a cohort of young women, and this is important. These were all young women in the prime of their lives. So young menstruating women. And by definition, to enter the study, you had to have been fat adapted on a ketogenic diet with measurable parameters for at least 4 years. So this cohort of women were all metabolically adapted and ketogenic. And she studied them for a block of time, for a month or so, and attained blood work. She also had them monitor their ketones, and it's really cool, take a photograph with their hands, a photograph of the food they were eating. So she had this detailed dietary record, she had record of their ketones, and then at the beginning of that month and at the end of the month, they did a detailed analysis of blood work. I mean, it is blood test after blood test after blood test, looking at the standard metabolic parameters, but also in a really cool way, looking at a number of the inflammatory molecules, inflammatory blood work, as well as some of the so-called aging blood work. And these are all found in the paper itself. They then, and here's the cool part, they then used something called the Eat Well criteria. Now, what's Eat Well? In America, we've got the food pyramid or the food plate, which is the standard government recommendation of basically a high carbohydrate, low fat diet. In the UK, in England, they have a very similar food plate put out by the government, and it's called the Eat Well plan. And the average carbohydrate consumption on the Eat Well plan is 267 grams of carbohydrates. Actually, quite frankly, not a lot based on what most people eat on the standard American diet, standard UK diet. But they used the recommendation of 267 grams of carbohydrates per day, and they switched these women from a primarily ketogenic diet to a Eat Well diet for 1 month. And they tracked their ketones every day. They tracked their meals every day. They kept accurate records. And at the end of the month, they did blood work. And then they put them back on their former ketogenic diet. And they repeated the blood work a month after that. So they've got three groups. The regular standard ketogenic diet over four plus years, the transition to an Eat Well diet for 1 month, and then a return back to the standard diet for a month. And they studied them and they did detailed blood work parameters. And it really is a fascinating study because it is not an epidemiologic study. It is a study of biochemistry and metabolic pathways and physiology. And it was exceptional in that regard. They also, the other key things about these folks, they were all young women that were menstruating. They were not on birth control, and they were non-athletic. These were women that may have been physically active because they were obviously all type A personalities, but they specifically were not athletes. A little bit like myself and Isabella, as you'll see, a little bit more on the nerdy side, but not athletes by any means, despite the shirt I'm wearing. And so what they did during the study is they studied a number of the standard metabolic markers. And as we talk about it, we'll go through kind of what they studied. And really what's interesting is we're now in the holiday period. And in fact, if any of you have been on a ketogenic diet or fat adapted and kind of screwed up over Thanksgiving, screwed up over Halloween, or screw up over Christmas, but then you get right back on the wagon, this is kind of what happened. It's not giving you permission to do so, but you would have fit into this study quite nicely. So what they looked at is the protective and adaptive aspects of the diet, and then also the test of coming off and going back on showed the adaptive flexibility of this diet. And it was pretty impressive. It's not a randomized trial, so that is a criticism of the trial. It is a prospective trial, but it's not randomized, and it was set up that way. There's no comparison here. Randomization or crossover might have been a bit better, but that wasn't the intent. Now, on the Eat Well campaign, 55% of the diet is carbohydrate, 20% is protein, and 25% is fat. On a standard ketogenic or keto carnivore diet, you're looking at an upward of 75% of the diet is fat, less than 10 to 15% is carbohydrate, and approximately 20 to 25% of protein. And what's interesting for me is not only did they look at the standard metabolic markers, the insulins, the C-peptides, the glucoses, the lipids, they also looked at the inflammatory markers. And one of the interesting things, or the two of the interesting things, and this is what I learned from the study, they used something called insulin-like growth factor, IGF-1, which I am now going to be incorporating my own blood work. When you come to me for blood work, I'm going to be incorporating that because it is a marker of inflammation. The other one they used was plasminogen activator inhibitor, number 1, PAI number 1, and that is also a marker associated with inflammation. And that's actually clot breakdown. You form clots and you break clots down. The IGF-1 is the one that I'm looking for. They used a Keto Mojo, so shout out for Keto Mojo to monitor blood sugars and blood ketone levels. And as we said, everybody had a type A personality. The study adherence and the study monitoring was exceptional. Then what they did is, as they tracked the blood work, the question then also comes down to, is fasting enough? Because obviously, my friend Jason Fung, they've gone deep down the fasting route where you're not eating for periods of time. Well, these women maintained their fasting routine. In other words, their intermittent fasting routine. Their eating pattern didn't change that much, just what they were eating. And so the other part also here is that fasting was really not changed. So this is purely the changes that are a consequence of reintroduction of carbohydrates into your diet. And that was also an important aspect of this. And we really look at what happens to a healthy ketosis cohort, not people that have just recently used a ketogenic diet for metabolic therapy. And what they were testing here was really the effect of hyperinsulinemia. When you trigger high levels of insulin, what happens to your blood levels? And it really is an encouraging study to tell us that metabolic flexibility and metabolic health can be restored very quickly when you get back on track. So, except for those perfect people on the internet, most of us do have occasional little blips, occasional little going sideways. I don't condone that. But the other thing about this paper is it really helped me to understand what happens when I do screw up on occasion. And most of us normal human beings do. But the call to action there is get back on track right away. Don't give yourself permission to screw up, but if you do, get back on track right away. And as I said, this was a phenomenal study. I think one of the best papers to come out of the ketogenic space in terms of affirming health parameters. So this is just a preamble to discuss what the study did. And over the next segment are going to be the questions. And I really hammered Isabella as if I was sitting in the Chan Public School of Health and defending a vegetarian vegan diet system or defending the Eat Well campaign. So over the next few days, you're going to see those videos. But that is the context of the study, and brilliantly done. And there's more to come. I am the Carb Addiction Doc. I know this is an unusual format for our videos, but I was totally involved and intrigued with the content. And you'll see me be a bit of an arsehole intentionally. Hi, folks. This is Dr. Rob Sivas. I am the Carb Addiction Doc. And today I'm joined by some wonderful authors of, and I'm going to declare my bias because bias in our space is so important. And I'll be upfront with this bias. I just told Isabella this, that I believe that this paper that they've published, in my opinion, is the most effective paper that has been published in our space on ketogenic diets, on blood parameters, and it is an upside down paper. And the paper we're talking about is called Ketosis Suppression and Aging, the effects of suppressing ketosis in long-term keto-adapted non-athletic females. And yes, folks, that was English. Isabella will explain that in a little bit, that long diatribe. But let's go ahead and, if you won't mind, introduce to me your co-authors. Tell me who you guys are, what work you do, and what your biased background is in this space.
So my name is Isabella Cooper, and I do research in metabolic health, and I'm doing my PhD. It's in diseases of hyperinsulinemia, which I believe is sort of very upstream of the root causes or root causes of chronic diseases of aging, or whatever causes hyperinsulinemia. And the counter of hyperinsulinemia, if you keep insulin very low and you're not a type 1 diabetic, is you'll have healthy ketosis, which is explained in an evolutionary context. And so one of my co-authors here, Kenneth Brookler, who we met in 2020, very early 2020, and we got involved. Actually, Ken was running a project in bone metabolism, osteoporosis, invited me into a project as a fresh pair of eyes to look at this pathology, and we developed a relationship from there when we sort of discovered new things and published a few papers on that. And when you just meet other people who fire off ideas between you, and the overall group of authors in the paper are, well, I mean, you can see that the trial required a lot of people, because the attention to detail of what we did in the trial just required a lot of micromanagement on everything, because the amount of data that we collected and to get the level of compliance that we had in this trial required that level of attention. So they're all biochemistry trained, things like that, and immunologists, hepatologists, physiologists.
1 second quickly. Are there any epidemiologists on this list of authors?
None.
But why not? We live in an epidemiology world. How can you not have outcome study-based folks giving you guidance?
Yeah. No, I mean, my background is biochemistry. That's my background, and medical pathology, and yeah, I mean that's my background. I studied nutrition as well, but ultimately I like things to be sort of very empirically tested as much as possible, really. And so, of course, you can see relationships in epidemiology, but it's not, obviously, proof that it's cause and effect. I think
the comment there is that what makes this study unique and so special in a positive way is that it's not an epi paper. It's a throwback paper. It is a clinical paper that is based on what I call physiology, and biochemistry I see as a part of physiology, which is how the human body functions. And
the parallel to that is how the human body becomes dysfunctional. And what you guys have done here is basically reported function and dysfunction, and then the correction of dysfunction. And it's a physiologic statement. And that is somewhat unique in the modern era. It was the way we did science before. Science has changed to become epidemiologic. So, and then your authors cross the ocean, don't they? You've got some folks from the US, and the one that's more notable, and I was reaching out for this book because for those that don't know it, Thomas Seyfried has written a beautiful chapter in this book. It's the ketogenic textbook. But I think this paper, in a more succinct way, is a superimposed copy of what this big textbook talks about, at least for practitioners. So I'm going to ask you one, and then the other one is Adrian, that we know pretty well, that's very active in our group. I don't know all the authors, but those are the ones that jump out. So I'm going to ask you to explain the study and explain the title in a second, but this is something I want you to explain before. And I don't know if it was this particular journal. It's the work is published. It's a 31-page article, which is unusually long. It's a diatribe, not a paper, but it's published in the International Journal of Molecular Science. And I don't know if this is a standard of every one of their papers. I haven't looked this up, but right at the end of this paper, there is a disclaimer or a publisher's note. And I don't know if that is written into every paper, but it said the statements, opinions, and data contained in all publications are solely those of the individual author and contributors, and not of MDPI and or the editors. MDPI and or the editors disclaim responsibility for any injury to people or property resulting from any ideas, methods, instructions, or products referred to the content. Is that a standard disclaimer on every one of that papers?
Yes.
On every one of the published papers? It is. So
Yes.
I was reading that with my little biased hat on and wondering if that was just a disclaimer based on this absurd methodology that you're promoting, or if it was a standard.
It's a standard.
Okay, good. Because again, you can understand my skepticism. In my opinion, to tell people not to to be skeptical or to ask questions or distance yourself from the proper human diet is a little bit questionable. Okay, so I just want to clarify that. Now, go ahead and explain to me what the paper is, what your thinking was, what was your hypothesis, and how did you set about testing this hypothesis, and how did you create the paper or the study?
So it was sort of, you could say, multiple thoughts going on at the same time, and essentially one of them was at that time, for research to be able to conduct human trial research in UK universities, it was pretty much impossible to get the ethics to be able to study, essentially take a group of diseased people and put them into ketosis and study them, because, you know, most university ethics board basically think that you're going to give people a heart attack by giving them a high-fat, low-carbohydrate diet. So the odds of getting the ethics was pretty much zilch.
And I just want to stop for a second there, because that is such a salient point, is in an era where we're getting sicker and fatter, and chronic non-communicable disease are the commonest cause of death on this planet, we're not able to do the studies that are potentially geared toward improving us because of those metrics. If you wanted to study someone on a vegan diet or a low-fat diet, you'd probably get ethics approval.
Yes,
but because you put them on a high-fat diet and our smoking industry-driven lipophobia, there's already an inherent bias of ethics to say we don't know what's going on, but it's definitely not because eating fat is good. So therefore, I love the turning this upside down to be able to get ethics approval.
Yeah, and so that's what I thought at the very beginning. I thought, well, if I can't put people into ketosis, then why don't I just study people already in ketosis and have them suppress it and just do it completely in the reverse? Because surely if my intervention is to put people on the standard UK diet, that can't be considered unethical, because that's the government recommendation. So there's no way they could say to me, you know,
in fact, if anything, you probably would be saving these people's lives.
That's probably what the thought might have been.
And that is part of the hypothesis, though, is because already there's inherent bias that these people are healthy. And if you put them on the standard American diet, that is, or standard UK diet, which is the recommended healthy diet, you should, by that reckoning, improve them. And the hypothesis then should have been, we're going to make these people healthier. And then the opposite hypothesis is, well, what if they get sicker?
Mm.
But your ethical standard should be, these people are not well, let's make them better. Again, according to the dictates of the current. Is that, you understand where I'm coming from?
Yeah. I totally
Because
understand.
you and I have an inherent bias that what a ketogenic way of life is healthier. Everybody else says no, it's not.
Yeah.
Again, so we're actually disproving. You have disproved your hypothesis, not proven your hypothesis.
Yeah, it's true. It's true. I mean, thankfully, I've had really great supporters in my university in terms of being able to do this research, really. And they've really if they see people who are passionate and sort of can convince using literature, good, data, then they're actually quite supportive of being able to push forward and do some real research.
Exactly. And I just didn't come back to that narrative, because if you came before the US Dietary Guidelines, which is the committee's convening right now, and you said that the beginning point is a picture of health, they would tell you by their standards that's absolutely false. It's a picture of illness. So again, I love what, again, you and I are on the same page, but we've got to put in the context of empathy, standing in their shoes, looking at us.
Yeah.
And what you're doing is disproving that. But so I think that is an important salient point, because if you are anybody other than someone working in the ketogenic space, and you've surrounded yourself by like-minded people, then yes, it's an ethical study, but you're trying to improve these poor people's health, because they're going to have heart attacks and strokes immediately with those high cholesterols, and they're not on statins.
Well, you could also flip it the other way. If you say that my bias is that being in long-term ketosis is healthy, that means my bias is that going on the standard UK diet is not healthy, which means it's unethical.
That is right, and that was my
technically also means that my intervention is unethical in my bias.
Correct, but I understand. Yeah, that's exactly right. But that's why you flipped it around. Again, it's mixing words, but it really, because if I was at the Chan Public School of Health at Harvard, I would be telling you categorically that you are going to improve these people's health.
Yes.
Okay? Yeah. And that would be the working hypothesis of a study like this.
Yes, it would be.
So again, I put that out there for the audience to think about, because it is so novel in terms of its upside down nature. But go ahead. I will. My nature is to interrupt you a little bit to ask those quirky questions.
No problem.
Go ahead and tell me so that was the design of the study.
Yeah.
And how did you? So go, and you studied them in health, and then you studied them in better health or illness, because you didn't know what was going to happen. You had a hypothesis. And then you put them back to their baseline diet to see what changes would happen. And then you created criteria that you believe to be associated with better health. And you created other criteria that are associated with lower health. Because if their LDL goes up, you might think that's a good thing, but other folks would think that's a bad thing. So again, the bias is, it's not healthy or unhealthy. Let's see what happens. That's what a good study should be. And all too often in the epidemiologic world, the study is to prove a bias rather than to be inquisitive about what biologically happens. And in fact, biologically, I believe with this study, it disproved illness. And I'll come to that in a little bit. And that was part of the study design. So we'll go through that. So take me through the technicality of the study design.
Well, there was a couple of other reasons why we also did this study. The other one was throughout my own studies, I was always reading papers where a diseased group were put into ketogenic diet and then compared against the normative population's data. And I always thought this is very strange, because the normative population are not actually in ketosis. And I think that sustained ketosis, especially in people who've never been diseased, probably have a different signature on all these markers in actual fact. And so taking a disease set of people to compare them against the normative population didn't make sense to me. You should compare them against other people sustaining ketosis who don't have disease and never had disease. So that was another reason why to conduct this study. And then another reason to conduct the study was we were always being told, and patients and people are always told, a ketogenic diet is not only not sustainable, it's not for people other than, refractory epilepsy, special cases. And
Well, that's two separate statements right there.
Yes.
Because I think there's consensus. The one place there is consensus is the ketogenic diet is valuable for in epilepsy or refractory epilepsy. However, working in the field, this is an incredibly difficult diet to sustain for most people. And therefore, your population that have been able to sustain this is a sub-fraction of the bell curve of people. It requires authoritarian people who are very structured in their way of life.
Oh, definitely. I mean, it just like people who love a vegan diet, or just like people who love, a fruitarian diet, or,
anybody that sticks to a plan for 4+ years and it becomes a way of life, especially if it is somewhat challenging in the face of the abundance of the opposite stuff to eat in our environment, has to have a particular characteristic. And part of the question of the study, and I know that this was the study design, but to extrapolate to a broader audience, is that there are not that many people as a percentage of humanity that can, and even if this is the best diet out there, sustain it. So the sustainability is a character definition of this cohort of people.
Yeah, I would agree with that. Then another reason was often I heard that, if you go on a ketogenic diet and cut carbohydrates out, you will become carbohydrate intolerant and metabolically inflexible. And,
So again, I'm going to disagree with that statement. Those two are, and in my practice, that is not true. So this is what I want to explore with you. So becoming carbohydrate intolerant is different than losing metabolic flexibility. And both Ben Bickman and myself, I've coined this phrase on the clinical side. Ben has done this with his cells. We've got different phrases for it. And this is something I want to explore with you. There's a concept that I see every day in my practice called insulin suppression. And that is, it's not carbohydrate intolerance, it's the lack of insulin. And all of these women on average were insulin suppressed. So I'll explore that with you in a little bit, and I'll give you the data that we look at here in comparison to our own data in that regard. However, I don't want to, I'm getting ahead of myself a little bit. I just want to put that on the table.
Well, I mean, the thing is that, if you just think about, I always look at things in terms of evolution. So if you are in chronic, regular ketosis as your natural lifestyle, historically, evolutionary wise, we would have come across, some fruits or berries or some honey, or, depending on where you are, geographically, things like that. And to think that 3 weeks or a month of a blowout on carbs would make you like severely metabolically unhealthy, just evolutionarily didn't make sense. And so, to describe it as metabolically inflexible in a negative sense just doesn't make sense, in that respect. And so it was always with all of these posits, it was always like, well, we don't know, let's study it. Well, we don't know.
I agree. And there is a whole, again, these are little things you're throwing out. And this is where we nerd out a little bit, because there is, in the animal world, and we sort of fit into that most of the time, especially in hibernating animals, the concept of tolerable insulin resistance. I call it type 1 insulin resistance. Squirrels, for example, do that intentionally prior to hibernation. We don't hibernate, but that is a survival strategy where we tolerate insulin resistance to stock up on carbohydrates when they're abundant in the fall or in the autumn. But if it's 24/7 pervasive, that knocks it out. So you recruited 10 women, average age of around 32, which again is a very unusual study population, but it says something about this cohort that's different to other folks around that age. And of all the features of this cohort, what was the most astounding thing that in the modern era, you're going to struggle to select 10 women at 32?
Well, I mean, the spread of the age was quite large too. So the youngest was 18, 18 at the start of the study, and the oldest was 47.
But they were all premenopausal.
Yes, they were all premenopausal, and something actually completely by chance, none of them were on hormonal birth control.
Okay, that was the next thing that's the next step I was going to make. It's impossible in the modern era to recruit 10 women who are not on birth control. So
that was crazy.
Not only not birth control, but by entry criteria for the study, they could not be on any medication. Yes. So I wrote the whole BCP thing, and then right at the end you mentioned that they weren't. However, you didn't mention whether or not they were taking any additives or supplements.
No, I didn't mention it, but no one was, because we said to people, like, don't take anything that can mess with the blood tests, because if you're taking supplements, it's going to affect the blood tests.
Okay, and then the other thing you didn't mention, again, from a dietary additive perspective, were they adding fat to their diet, MCT oil, anything like that? And were they adding salt to their diet?
Right. So the whole point of the study in terms of saying suppressing ketosis, or rather, you know, and as additional to the fact that the participants maintain ketosis, we didn't instruct them how to maintain ketosis, because they already were doing this for years and obviously knew exactly how to do it for themselves. And that was, again, from my background knowledge of understanding that there's so much individuality actually in terms of what works for people. So, you know, we did take incredibly detailed food diaries. Our participants would photograph from a bird's eye view what they ate with their hand flat next to it, as well as their drinks. And so we have an incredible log on it. And it was really interesting. And blood tests, blood capillary finger prick tests were taken 4 times a day when you wake up, before lunch, before dinner, and before sleep, whether you eat or don't eat, and things like that.
That was one of the other brilliant things about the study, is so often they have recall studies. So the recent Walter Willett paper on red meat associated with type 2 diabetes, and they followed one of the nurses' studies. And I have several patients that are members of that study, and they get given a piece of paper or a questionnaire once a year to tell you what their dietary recall was for the previous year. And then that was used to quantify whatever the Harvard Chan Public School of Health did. And I mean, that is an impossible thing. I can't remember what I ate 2 days ago. So the fact that you did that with a photograph and proof, even though so it's basically saying, we don't trust you, show us those pictures, but we need that proof. So I like that methodology a lot. Yeah. When you look at that diet, and obviously we don't have a representation of the pictures, in the P1, the pre-criteria, what was the range of diets? Were there any vegetarians, and were there any pure carnivores in that spectrum?
There was actually a fascinating range. So there were definitely participants who were much heavier on plant-based. There were no vegans, but there were definitely more veering on the vegetarian. And then there were a couple of carnivores too. So it was very interesting to see those differences in that respect.
And when you looked at the P1 criteria, were there any, and I don't know if you know this term, it's a common term in our space here in the US, LMHRs, lean mass hyperresponders, because they were all lean mass. The BMI was 20, which is very lean, and certainly in the modern era. And the hyperresponder, I have my own criteria, but it's a LDL above 120, a total cholesterol above 200, triglycerides below 75, HDL above 75. Dave Feldman has slightly different criteria, but they're about the same ballpark. And were they all LMHRs, lean mass hyperresponders?
Pretty much. Not all, but statistically so.
What was the average total cholesterol of this group?
Oh my gosh. I'm
looking for it myself now. And
the paper.
Yeah, I've got the paper in front of me. I'm just it's 31 pages. I don't recall what it was. But one of the things, if I read it through again this morning, it's now the afternoon when I'm doing this. But one of the things that I've seen in my practice is the super high LDL and the super high total cholesterol is indicative of insulin suppression. And you mentioned this as part of your paper, is that insulin triages HMG-CoA reductase, HMG-CoA synthase. I'm going down biochemistry, so tapping into that. There's a branch point, and the synthase shifts lipids toward ketones, and the reductase, which is insulin-driven, high insulin drive, shifts lipids toward cholesterol production under the influence of T3. And you did study T3. So if you look at the biochemistry behind that, that is a branch point. And whether you're ketosis or high cholesterol, it's governed by insulin. And when you're low insulin levels, super low insulin levels, you're producing ketones, but you're not making enough cholesterol at a hepatic level. However, so why is their cholesterol high? Because insulin also regulates cholesterol uptake from the diet. So these folks are typically on the LMHRs are on a high fat diet, often 75 to 80%. And this cohort was 60+% fat. And a low level of insulin results in a much higher absorption of cholesterol. So when you lower insulin levels, your cholesterol typically goes up. And that happens with insulin suppression.
Yeah, I mean, the thing is that you've got ketones in the liver. Everyone always says the liver can't use ketones for fuel, which is true in terms of ATP synthesis. But the ketones are actually used for cholesterol synthesis, both in the liver and in the brain.
Yes.
So obviously it synthesizes cholesterol. But the next thing, obviously, aside from cholesterol's purpose and membranes and purpose around the body, its purpose in digestion, in bile acid, is for the absorption of fat and the fat-soluble vitamins, A, D, E, K, and the essential fatty acids, omega-3, omega-6, and the reuptake, whether it's coming from diet or the self-synthesis, endogenous, taurine. And so if you are having a diet that is, naturally higher in fat, then, it's going to also make sense to synthesize this cholesterol to facilitate the uptake of the fat and what the fat brings in with it, in natural foods that would contain these fat soluble vitamins and essential fatty acids and things like that. And you're going to be absorbing it as well, right? You're going to be reabsorbing. And one of the things that I didn't put in this paper because the paper was so long, it was actually 20,000 words, and I reduced it down to 12,000 words. So it would have been a lot longer, was the explanation that, it's just some background stuff. When you have a high fiber diet and a high vegetable oil diet, they do what they say on the packaging. People talk about eat lots of fiber and have a high vegetable oil diet, and it will lower your cholesterol. Well, it does do what it says on the packaging. It will lower your cholesterol. It will bind to your bile acids, which contains your cholesterol, and take it out of you, which also will deprive you of what your bile acids are trying to absorb into your body, which is those fat soluble vitamins and essential fatty acids and taurine, which is so essential for mitochondrial function.
Right, and from on the flip side of that, I agree completely with everything you said. That's standard biology for me. In studies where they've tagged cholesterol and they've looked at absorption versus production, it's governed by insulin level. So the lower your insulin level, the more your absorption and the lower the production. And in my own clinical practice, when I see an LMHR who is insulin suppressed, and the reason why it's important for me, and again, this is all questioning these women that are in deep ketosis, because if you look at insulin, and this is what most people don't think about, because Banting and Best discovered insulin in a diabetic, in a type 1. So our focus is that insulin regulates blood sugar, but that's not true. The regulating hormone in a healthy person of blood sugar is glucagon, because it's a production molecule, and insulin is just there at very low levels to allow entry into certain cells. But insulin's primary role is as a regulatory hormone in the nucleus, where it regulates gene transcription, protein production, cholesterol production, steroid synthesis. And the concern for me in the LMHR population, in these women that have been in ketosis for a long time, particularly if their diet involves a very, very low carbohydrate consumption and a high fat consumption, is a lack of insulin production. And so here's another little element that we've discovered in our practice, and it's opposite to what we were taught in physiology class by Tim Noakes 50 years ago, 40 years ago. What Does elevated blood sugar trigger insulin release?
Does elevated blood sugar trigger insulin release?
Does
So,
hypoglycemia trigger insulin release?
well, I guess are you talking about it from a one-off exposure rather than hypoglycemia that's constantly just high because of liver output?
Doesn't matter. If
Okay.
I put an IV into you and I inject sugar, or in the human body, if you convert excess protein to sugar, to glucose, and you release that into the bloodstream, and your blood glucose goes up, which is a common phenomenon in the LMHR group. In other words, they're getting, if you're not eating carbohydrates, you're getting your glucose from gluconeogenesis under the influence of glucagon. What happens to insulin under those conditions?
It'll be synthesized and released. Obviously, what we found in our participants, obviously there's a delayed release, as in.
Well, I'll come to the oral glucose tolerance test. It is an important consideration because that's what we're taught, but it's false. In other words, if you look at, and it's evolutionarily, it's understandable. If you look at glucagon being the dominant hormone, your blood glucose levels, when glucagon is creating gluconeogenic glucagon release or glycogenolysis in the liver, your blood sugar is going to be at a low level. So you need very little insulin to get that into the liver.
Very much
so. To get that into the cells. So your insulin level is low.
Yes.
And the conventional teaching was when your blood sugar goes up, your insulin gets released. But it's not an elevation in blood glucose that triggers a dominant release of insulin in the body. How do we know that? Because in this group of folks, our LMHRs, our carnivore LMHRs, they start to see a creep in blood sugar and a non-response with insulin. So they have a Kraft pattern 5, almost like a type 1 diabetic.
No, they had pattern 1s.
Yours were all pattern 1s. We're going to come to that in a second. However, when you then in that group introduce a little bit of carbohydrate, not enough to raise blood sugar because it's got to go through the liver, but enough to trigger GLP-1. GLP-1 and maybe a couple of the other incretins, which we're still exploring, are the primary triggers of insulin released by the pancreas. And evolutionarily and physiologically, it makes sense because nowhere in nature are you walking around with an IV going in. And if you're a carnivore, you're functioning at low level. But my concern in my patient population is that the lack of insulin, those low insulins with slight hyperglycemia, means that the insulin is not there for other purposes of insulin. And if you trigger GLP-1, they will then raise that insulin a little bit.
I think that the thing is though, your patient population are people coming to you who have metabolic disease as well.
Not true.
No.
I've got over 1,000 pure carnivores that we manage. And my longest carnivore is over 20 years carnivore, similar to you. So, no, that I see a lot of sick people, but I also, just the nature of our practice, we see a lot of people who want corroboration that it's healthy.
Okay.
And then they can't understand why their A1C is going up. And it's not because the red cells...
It's really funny you should bring that subject. We were just talking about that in our lab today.
Because if you look at that, Paul Mason may say, oh, it's because red cells live longer. But why is your BUN higher? BUN is a breakdown of protein. It's nitrogen breakdown. Why is your uric acid going up? Why is your creatinine going up? So the protein markers are going up. And we can talk about that at length. The point about this study and why I point that out is because what you just said earlier on, I had to answer my own question, are these people insulin suppressed? And if they
just measured GLP-1 today.
Oh, you did? Okay. So, I mean, those are useful things, useful markers, but you're right. All of yours fit into a Kraft 1, which is insulin sensitive. But if they flip over to insulin repressed, they become Kraft 5s.
So all of our phases were all Kraft 1, all of our phases.
Right, and that is by insulin measurement, not just by sugar, by glucose. So if the insulin stays below 30 units for me. Now you did
and looking at the pattern, you know, the return to baseline and all these things. Now we say Kraft 1, but you know, as we've said in our paper, it comes with this U-shaped BHB curve when you're in ketosis. So that's, you know, it's a subcategory then of the Craft one, Craft
Well,
one.
insulin sensitivity and BHB are two separate things because
They are, yes, but it's just showing, there's obviously some sort of switches and gates difference in this respect, because in one setting the liver sees insulin and it's like BHB has not been synthesized at all, and yet it's responding to glucose uptake and things like that, and then not in the other setting. And so I just think, because we always hear about sort of this insulin resistance idea of the liver, and so to show that in certain states it's not pathological that the liver putting out glucose is, if it's not coming from your diet, it's really got to come from your liver, and evolutionarily it really wouldn't make sense that a one load of carbohydrate that you end up having all this insulin released, that your liver would then shut down from producing glucose as well. This could be very dangerous evolutionarily. Now, with regards to GLP-1 and the other insulin secretagogues, well, we've run those assays, and we will be doing the actual data analysis tomorrow. So I'll be able to.
Yeah, the other part also is in the Craft 5s, when their sugars go up through gluconeogenesis, the beta hydroxybutyrate goes down. A lot of these folks, as you've seen with this population, they're fastidious about using their Keto Mojos. Shout out to Keto Mojo, very supportive of them. But we see a drop, and that's often they come to me and say, I can't get into ketosis. I'm pure carnivore, I can't get into ketosis. And when we look at their metrics, they're protein dominant, not fat dominant. And the body is desperately trying to clear protein. There's no store for protein. So it has to go through a conversion to glucose, and then the triglycerides go up because it's converting it to fat in the liver. But they're also a little hyperglycemic. So again, that is more than nerding out on this, but and when I ask that question, because when I look at a study like this, is are they insulin suppressed or are they insulin sensitive? And your population is, with very low numbers, insulin sensitive. Which
our population actually could, so for example, you always hear about a ketogenic diet being less than 20 grams of carbohydrates, things like this. Our population was actually able to have a lot more carbohydrate than that in their ketosis phases and maintain, therapeutic levels of ketones. And that's obviously because they haven't developed so much metabolic derangement that they have such a low tolerance. So
I think that's an important concept, which a lot of people don't understand, is the difference between who's the puppet and who's the puppeteer. And the puppet are the substrates, glucose, fat, and protein, or lipids and protein. The puppeteer is insulin, glucagon, the incretins, the thyroid hormone, testosterone, and I didn't see you measure testosterone, but the hormones are the puppeteers that regulate the substrates. And then the final piece is the receptor for the hormone. And receptor upregulation, receptor phosphorylation is as much part of this. And that takes time, because the injury to the cell by intracellular hyperglycemia is tolerable for a while and then not represented. So along those lines, just let me ask you this question, and it's a statement that raised an eyebrow with me, because I'm going to make a statement and you can refute it. There is no way, in my opinion, that a group of type A 4+ year carnivore or ketogenic women are not going to do at least 3 hours of something physically active every week. And you call these non-athletic. So what was your descriptor? What was the threshold for calling someone athletic versus non-athletic?
So essentially moderate activity. So they certainly don't go to the gym. If you go to the gym, you don't go to the gym more than 3 times a week, and you wouldn't do more than an hour if you were at the gym, and it's not going to be anything above what a regular healthy person could handle. And so they're not really sort of people who are, regularly training for a marathon, do, cycling to work for an hour and cycling to work back, cycling back, and, just sort of more on the athletic side, and sort of could start to veer into some level of competition. It's really sort of your average.
Isn't that excessive athleticism? I published a paper that we've just reviewed that hasn't been released on this channel yet, is about how much physical activity is necessary. And it's kind of, again, a bell curve. And the standard is 3 hours of moderate intense exercise per week is the optimal amount of physical activity. When you go more, when you're running marathons and
that's possibly not so good for your health. It's
correct.
true.
And that's what
we were looking specifically at what would be more akin to the standard healthy population, which is what most people would consider sort of like that's some level of like you're not sedentary. That was a main thing that we're
these are not athletes, but they're not non-athletes, because a non-athlete for me is somebody that has to use a winch to go to the bathroom to get out of their chair.
Okay, so we were defining non-athlete as in they were just like not part of a basketball team, not part of a cycling competition sort of thing, not sort of like anything you could consider, yeah, I'm a quite athletic person. It's just sort of like, if I'm lucky, I'll find 3 hours in the week that I might pop to the gym, but that's about it.
Right. And the point there is that physical activity regulates the hormonal system as much as the liver does. And in fact, a lot of type 1 diabetics who are managing their type 2 component really well use physical activity as a way to manage their blood sugar. So again, that is just something in this paper that didn't make sense to me. You can call them non-athletes because they are actually athletes. They're just not nth degree athletes.
I understand what you're saying. I mean, we did stipulate inside of the paper, moderate activity, which has a stipulation of like around about 3 hours worth of, like, if you were to class it as exercise, because again, the way when we ask the questions of our participants, it sort of quite often be like, well, I don't go to the gym, but my job entails, but I'm walking a lot, and so then you sort of work it out that they're not sedentary in that respect. These are women.
That's just something that's important to understand here. And I understand that this is your cohort, but it's not necessarily.
So, for example,
from an athletic perspective, my patient population is non-athletic when the obese folks, but.
So we have some of the participants were mothers, so they just wouldn't really have the time to go to the gym. And then, some of them were students and their walking was walking around university, going to university. And so we were just looking for people who were definitely not outside the normative population range in terms of level of exercise that you'd start to, say that person's quite well trained actually.
And then the other, just a complete segue away from that, did you give any of these folks guidance about fasting and snacking, meal frequency?
In their ketogenic phases, no, because it was to measure them however they work, because the idea is we're studying people who maintain ketosis naturally, like their own lifestyle. We're measuring, and so we didn't want to influence that at all. And then obviously the intervention being to suppress ketosis was following the UK Eat Well guideline. And in that, the Eat Well guideline stipulates how much carbohydrate for women. It actually says no less than, so you technically could surpass the amount, and with a frequency of 3 meals a day and snacks in between. And our participants actually were, some of them sort of were more the 3 meals a day, and others were slightly smaller 3 meals a day with, a piece of fruit or a granola bar, that sort of thing. Interestingly, because our participants were so out of the habit of eating carbohydrates, they sort of, because of, we had to give them examples as well, of what the sort of standard eating habits were. And we did say, look at your colleagues when you're in your office, watch your colleagues, look at what they do, to get them to sort of recognize those eating patterns or what other people were doing. But it was very interesting to see how their habits had obviously become so ingrained in their lifestyle that they sort of, didn't really think that the average person thinks that a freshly squeezed orange juice is very healthy and natural for breakfast, as an example. And so even during their carbohydrate phases, they actually weren't drinking juices or anything, even fresh, cold pressed or any of these sort of things. So, if I was to redo this whole study, maybe I would sort of give more pictogram sort of examples and things like that. But my participants did really well though, still, because they really sort of did look to count the carbohydrates to have a look at were they coming up to what was required of them.
Now, you know, that's where the frequency is important, because Jason Fung will tell you that the carbohydrates at first are less important than going long periods of time without eating, and to get that cyclical ebb and flow between glucose and insulin. So the fasting community are less focused, at least initially, on the carbohydrates and more on the protracted period. So the eating pattern is an important thing. The second thing that the guy that I was on my PhD committee, which is the father of the whole glycemic index, David Jenkins, and he will tell you that glycemic index is probably more important than glycemic load. And did you calculate, or did you look at glycemic index versus glycemic load in what these folks were eating?
No, we didn't. So, I mean, obviously we've got the data for a lot of data analysis for further papers and things like that. Again, so as a group average, in order to not wake up with ketones the next day in the phase 2 of ketosis suppression, I think it was the 5th or 6th day before it was that everyone would wake up with no ketones at all. So even with the 3 meals a day carbohydrate, it was actually quite hard to really properly kick them out of ketosis where they weren't waking up. And also, because our participants actually did test more than 4 times a day, they did test a lot more than that, and they were going back into ketosis quite easily, you know.
And that's, so I would use a different phrase there. There's a big difference between being in ketosis and being fat adapted.
Yes.
You can drink a bottle of olive oil and get into ketosis, even if you are 80% carbohydrate diet. You can consume one of these boys, a ketone IQ, and get into ketosis no matter who you are.
Yeah, exactly.
But fat adapted is where the cells preferentially use ketones and fat, and 80% of most cells is non-esterified fatty acids. Ketones are just a tiny fraction. So that's understandable. And the biology doesn't just turn on one day.
Yeah, exactly. Exactly.
And we'll come to that, because that's one of the criticisms I have of this study is 21 days. And for folks like this, 21 days is a blip.
It is a blip. Yes.
And it's a tolerable blip. So they've proven tolerance to a 21-day blip.
Yes.
And
exactly.
so we'll come back to that in a little bit. But another just a little question, and you mentioned this and you didn't talk about, what's Hayflick limit?
The amount of times a cell can replicate before things go, you know, very bad and the cell essentially dies. So different cells obviously have a different Hayflick limit before, you know, so a red blood cell, an adult red blood cell, that's it. It doesn't, you know, divide. It will, you know, do its job.
Red blood cell's a bad idea because it's got no nucleus.
Yeah, exactly.
But
you have, you know,
as no division as far as we're aware, maybe a little bit. The skin and the mucosa is turning over all the time. That's
exactly.
And the key, so why did you even mention that? What is pertinent to our understanding of cell division?
So, you know, cells divide for healthy reasons. They also can divide for unhealthy reasons if they're dividing faster than their natural rate of what they should be dividing. So let's say a cell is supposed to divide, you know, once a month, but suddenly something is making them divide once every 2 days. That's obviously a division rate that is faster than its natural physiology. And this is where you see cancer, where cells are dividing much.
And what is the regulator? What is the primary metabolic regulator of cell division rate and frequency in different tissues?
So are you talking about outside of the cell? What's the regulator, or what's the regulator inside of the cell?
In the nucleus.
So the actual regulator is the mitochondria that's not in the nucleus. It's the mitochondria. Insulin resistance is going to drive, you know, it's sort of bidirectional insulin resistance and hyperinsulinemia. And so the amount of insulin and the frequency of the higher amount of insulin is going to affect your rate of cell division and the quality of that cell division as well. See what I mean? And then you're also going to have a combination, because sometimes the higher level of insulin can actually just cause cell death, whereas obviously chronically sort of subpathologically high levels of insulin, where you get a lot of damage, is going to cause so much damage that but it can't cause cell death. And this is where you have the problem with the cancer, because you're getting the signal to divide, but not the signal to die. And in actual fact, the primary regulator of apoptosis, cell death, there are multiple things that can actually cause it, but, you know, on a hierarchy, it comes from the mitochondria. And because the insulin is directly causing an excess of mitochondrial fission, which is a natural physiological thing to do for cell division, but it damages the mitochondria's ability to commit apoptosis. So when you've got this chronically elevated amount of insulin, you get this morphological change in mitochondria, that they have a downregulated ability to be able to kick in this controlled cell death. So now you've just got, you know, uncontrolled replication instead.
And that's at an extracellular level. And I was looking more at the nuclear level. What we've seen in our practice, and I've spoken about this a little bit, and we're about to publish on this, is a bell curve of genetic insulin production capacity versus insulin resistance. And so we can measure in our, and again, this was an inhomogeneous population with regards to what I'm about to talk about. All of these women were skinny, and the question is, were they skinny because they couldn't be fat, or were they skinny because they weren't at liberty to be fat? What do I mean by that? Is that when I look at our population, and it's a bell curve, but I'm going to give you the two distinct ones. There is a group of people that when we measure their fasting insulin, it's ridiculously high, but their blood sugar, their blood glucose, and their A1Cs are normal. Or maybe low threshold, 5.4, 5.3, 5.2. But the fattest person, the heaviest person, most often has the lowest A1C and the highest insulin. On the flip side, you've got super lean people who, and our East Indians I was just talking to a couple of, I have them as patients and a couple of them today, but they may be super lean or slightly overweight, but have an A1C of 7.1, 7.89. You know, it's been the diabetic range. This one today had a 7.1. And their insulin is elevated above what I would consider normal, but it's not super elevated. And so in the obesogenic, these are phrases I've created, the obesogenic population, there's just no way that they're going to have hyperglycemia, but they have massive hyperinsulinemia. Whereas the diabetics have modest hyperinsulinemia and significant hyperglycemia. And the disease spectrum is different between the two populations. The diabetics have vascular and neuropathy disease, because that's where it's a disease caused by hyperglycemia, not necessarily by insulin. Whereas the group that have normoglycemia have diseases caused by persistent, significant hyperinsulinemia. And the obesogenic group is far more prone to cancer, to autoimmune disease, and to Alzheimer's. And you mentioned, which was a very interesting thing, because it's not quite the same in the US, that women in the UK are most likely to die of Alzheimer's, of dementia. Here with us, it's number 2, but that would be the obesogenic group. The diabetic group typically dies of cardiovascular disease and stroke. And they have so we've seen a polarization, obviously on a bell curve, but eventually even the obesogenic people will cross over. And that's the worst state, where you are hyperinsulinemic as well as hyperglycemic. But that's been, and what I try to look at in this population is there within these 10 women some way to distinguish that? But you didn't give me the data I needed. No BUN, no creatinine, and those are all numbers that I look at to see which way they're leaning. And you also didn't do a C-peptide. So why did you not look at those numbers? Or did you, and you didn't publish them?
We have just run C-peptide today again. So we were just doing some panels today. It was a very long day. We started at 7 a.m. and it's 11 p.m. now. So we're actually running a whole load more markers. And that was the intention, to run more markers. We do have things that we had run that are not in the paper. And it was just basically the paper was so large that if we did anything more, we'd be rejected on publishing just because of how big it was in reality.
I think that's an important statement. It's going to be very useful, because really this was a delineation of so-called health markers. And even if you can publish that as a cohort, as a statement paper, rather than in a study, to say these are the ideal parameters, and this is where it varies, which are not the standard normal tables. But the C-peptide is what the pancreas produces, and it's the highest number that your insulin will ever be. And insulin is measured as far away from C-peptide as can possibly be present. It's measured on the venous side, after the liver, after the organs, after the lungs, on the back end. And
we're measuring total GLP-1, active GLP-1, C-peptide, glucagon, osteocalcin, serotonin, melatonin. We're measuring all.
Well, right. And the other interesting thing about GLP-1 is that GLP-1 cannot directly affect the pancreas. So this whole, because if you think about it, GLP-1 gets released into the portal vein and has to go through all the organs onto the arterial side to get back to the pancreas. Because the pancreas, the veins enter the portal venous system, but the arteries through which GLP-1 come have gone through all the organs at least one cycle, including the lungs. So looking at the anatomy and the flow of these hormones through the body is also a large part of what we look at. But again, I'm nerding out on that. I'm getting beyond myself. So when you answered this a little bit, but I want to come back to it. What was the typical starting diet? What was the range of diets of the 10 women starting in P1?
In P1, the range of diets, do you mean sort of macro types of food?
So if you look at plants versus animals, do you have an idea of what that you said? Some were vegetarian, but not vegan. Some were carnivore. With a majority, and which way did they lean? More toward plants, more toward animals?
We had so we're looking at the 10 participants. I would say there's definitely 2 that were veering on a lot more plant-based foods, and there were 2 that were definitely veering more on the carnivore side, and then the rest were kind of relatively omnivorous, you could say. So there was always sort of meat and veg on their plate, so to speak.
And okay, so again, that's because it's a variable population. Because all carbohydrate, all vegetables by definition are carbohydrate.
Yes.
Whereas carnivore, unless you're doing dairy, there's really no carbohydrate.
Yeah. Well, this is the thing. We didn't control the carbohydrate.
It's just data.
We literally were looking at people who sustain, nutritional and above level of ketones their own way. And so, if you were really sort of counting starchy farinaceous carbohydrates, they wouldn't not have it. I mean, if you're looking at the food diaries, there were some that, would have a glass of wine, not terribly infrequently, berries, some chocolate, even some starchy vegetables. They weren't not having anything. And again, that's because these were really healthy, long-term healthy, so their carbohydrate tolerance was actually, that's sort of why I wouldn't do a nutritional analysis and measure out exactly how many carbohydrates they've had and then say everyone else should go and copy that, because unfortunately the vast majority of the public are metabolically unhealthy, and I would hazard an educated guess that they probably wouldn't be able to tolerate the amount of carbohydrates that these participants were able to while sustaining nutritional ketosis.
Right.
And so, that's why it wasn't a sort of, we're going to control what everyone's going to eat and how much carbohydrates that they have. These were free living women eating, in a way pattern that they've been doing for years. And we didn't want to alter that at all. And
I think that's the beauty about the study, is this sort of variation of people in ketosis. And it really because there's a big push that there's almost in our space, in the clinical space, what I call keto shaming, that if you're not carnivore, you're not a true, and I think that's a narrative that has happened on the internet. But what you've proven is that it doesn't matter if you're more on the vegetarian side, more on the carnivore side. It's the ketogenic side of things. It's the absence of the carbohydrates that are more important than what you actually are eating. And that was an interesting phenomenon of this, that the carnivores weren't better in any way.
I would say that's true for this group. I can't say
that's all you can comment on, but certainly there was no bias or no shift one way or the other. Calculate, because I didn't see this, I may have missed it, but did you calculate average caloric consumption in P1, P2, P3?
We We did, but we didn't obviously put that into the paper. We had the participants do sort of random days, just sort of do a calculation on, you know, things that they had package descriptions and things like that. And they looked pretty similar in that respect. They weren't, yeah, they were sort of like
you know that it doesn't matter what substrate you eat. What matters is your calories.
yeah, I mean they didn't
I'm being facetious there because
right,
that's
okay, yeah. It didn't look like they had a huge difference. I mean, you know, that said, I mean, I would, because you know, the data that I've just looked at is me eyeballing and just looking rather than doing a proper statistical analysis. So I couldn't make a claim unless I actually did some statistics on it.
Here's where I'm going. Here's where I'm going with it. So let's assume they were fairly isocaloric, that there wasn't a massive increase in overall caloric consumption in P2. You reported that they all gained weight.
Mm.
And they gained water weight and they gained fat weight, and yet their RQ went up. Now, the RQ goes up because you're burning fat, not sugar, but it doesn't make sense to me.
The RQ went up, so they're burning sugar and not fat.
Correct. That's what I mean. So, I mean, the RQ went up in P2.
Yes.
Okay, which really means, and again, you can tell me if I'm wrong, but that their metabolic rate went up in the P2 category.
When you say metabolic rate, you mean you're saying like the amount of calories that they're burning in that respect?
The only information you gave me was RQ.
Okay, so RQ is like burning which substrate they're burning, right?
Correct. Exactly right.
Yeah.
And we know that each element has a different RQ, and you can tell whether they're burning fat or sugar based on the RQ, 1 versus 0.8. God, that's a throwback for me from 35 years ago when I last did biochemistry as a student. It's amazing how that memory stays. But how is it if they're isocaloric and the respiratory quotient goes up, which means they're burning those carbohydrates more so than the fat?
Yeah.
What is your speculation as to why these women gained weight if they were isocaloric? What was happening that resulted in weight gain? And I'm going to subtract the obvious hydrophilic component of glucose. Fat is hydrophobic, glucose is hydrophilic. And therefore, when you eat a high carbohydrate diet or moderate carbohydrate diet, there's an expected retention of fluid. And that's why I asked about salt earlier on. You didn't measure that. But and you accounted for that very nicely. You accounted for water weight and then you accounted for fat weight. But these women also gained a significant amount or a measurable amount of fat. What is your theory? Why did that happen? Because they're isocaloric.
Yeah. I mean, you know, again, this is assuming it was isocaloric in that sense, because it was an ad libitum, you know, to satiety, and let that be their guide. And I would actually throw it out there. I bet you, I haven't actually done this analysis, but I bet you if I actually really did it like thoroughly, they probably had more calories when they were actually in the keto phase as an actual fat, because the amount of fat that they consumed was quite extraordinary.
That's supposed to appetite, whereas sugar drives appetite.
Yes, this is true. This is true, but because
they were isocaloric,
you assume they were isocaloric. I mean, there's going to be a number of areas where because it's, you know, in biology, there's never really one thing. It's not one directional one thing. So you're going to have a number of things, aren't you? You're going to have, so in an evolutionary context for women, you know, for men and women, it's happening both at puberty, why insulin goes higher, and then for women, obviously, it's during your menstrual cycle, but then particularly pregnancy. And so, you know, higher levels of insulin during pregnancy, that happens naturally. I'm not talking about gestational diabetes. It's part of this process of making sure that the body is going to now take in more and store more, you know, in order to grow a baby. And, you know, not just grow the baby, but to store more on your own body. So
let me give you a slightly different scenario that's more pertinent to this. Would you agree that under conditions of infection or inflammation, your metabolic rate goes up?
Yeah.
Okay. And if your metabolic rate goes up and you are consuming a eucaloric diet, then you should be losing weight.
If your metabolic
spending more calories if you're inflamed. And, you know, if you look at someone who's had a burn, their caloric consumption goes through the roof because of the inflammation of the burn. And that is true for any infection. So the paradox here is you demonstrated with the numbers that their inflammatory markers went up. We've kind of surmised that they were eucaloric in their consumption. And yet the P2 group gained weight. I have an idea, but that is an irreconcilable, at least superficially, problem. So you got the same number of calories, your inflammatory infection rate is going up, your CRP is probably going up, you're probably more metabolic, there's a greater metabolic expenditure, and yet you're producing more fat.
I mean, our participants' CRP didn't change. It didn't.
Yeah, not significantly.
Yeah, it didn't.
Right. So the CRP didn't, but all the other inflammatory markers did.
Yeah, so the growth markers ones really, because the cytokine ones didn't as well. So it was much more at the growth factor ones. Now, if we did 61 days, not 21 days, maybe that would have been so different.
But you'd be dealing with a different problem then.
Yeah.
You may be insulin resistance, but your vascular inflammatory markers went up.
Yeah.
The PI went up. So that's the first level of hyperglycemia is in the vascular space. But generally, those are all markers that are indicative of inflammation.
Yes, absolutely. Yeah, it's just that they're different types of inflammatory markers, and so the types of inflammation that they elicit, if you look at them separately, it's just that most people would have assumed the CRP would have been an earlier mover, rather than sort of we're seeing these inflammation growth factors without the changes in the CRP and the cytokines, which was very interesting.
Well, so I'll give you my, again, based on the data, the thoughts, because this is an important concept when it comes to why can't I lose weight and why am I gaining weight? So what you demonstrated with your Kraft tables is that they didn't come out of pattern one, but their insulin production went up significantly when challenged with a glucose load. And insulin does two things. Insulin drives sugar into cells, and insulin blocks the mobilization of fat.
Very much so.
So even though they were eucaloric, the puppeteer, the insulin, by being elevated, is going to increase storage and minimize utilization.
Yes.
And that probably explains the gain in weight, even though they were isocaloric. In other words, it's a hormonal regulation, not a caloric regulation. And that's an important concept against the SICO people, the calories in, calories out people.
Yeah, I mean, what the food, all foods contain calories, but what those foods obviously are made of and the hormones that they signal are going to alter how the body responds to those food sources, the energy from those food sources, whether you're going to store that or whether you're going to burn it or, turn it into heat or pee it out or breathe it out, things like that. And so, the hormonal effect of those foods, which is, by the way, why we didn't do a controlled calorie diet and we went with ad libitum, because often there's so many studies where, it's going to be deliberately isocaloric. Everyone's given a keto, drink, or a plate, to eat that's so controlled where, again, it's not taking into account different people respond to different foods in actual fact. But by making a deliberately isocaloric comparator with keto and carbohydrate loaded meals, you're overriding the effects of things like leptin, the satiety signals. And by overriding it, you're not letting natural biology take its effect in actual fact. And so I think that in the science sort of obsession of you have to control for absolutely everything and change this one thing, and I think it's quite flawed in actual fact. It's like, giving vitamin D without vitamin K, or looking at an enzyme without its the metal that needs to come with it. I
call that metabolic isolation, looking at one number, because homeostasis is a complex pathway. However, I was just looking at, that's an interesting commentary in a positive way, that these women were able or gained weight And whether they triggered an increase in caloric consumption or not, I don't know. The one group, and I think this would be a very pertinent current study to do